Hey everybody, welcome back. Today we're going to go through immunopathology. So remember in immunology we've studied about the innate and the cellular immunity. So just as a recap, innate immunity is automatic. There are certain activation factors, such as the cells recognizing some very, very general, like cellular signals from pathogens. These are not specific, so that's really important. There is non-specific recognition of the pathogens and damaged cells. It's eliminated by natural killer cells. There are no memory, so each time around, it does take a little bit of time for the reaction to occur. And the reactions are going to be the inflammation, along with type 1 interferon being released, and the danger signals, which can be cytokines or interferons or TNF. Okay, so the receptors are going to be recognizing the PAMPs or DAMPs. The PAMPs will come from the pathogens. The DAMPs are coming from our damaged cells. So the toll-like receptors are going to activate NF-κB and the interferon regulatory factors once these have bound to it. So, like as you can see here, PMPs will they're going to bind to the toll-like receptors and be introduced in the cell. And then there's another receptor that allows the interferons to go into the nucleus to affect transcription, translation. Sorry. So the NOD-like receptors are going to recognize uric acid and ATP from the necrotic cells, along with ion disturbances and the microbes. They're C-type lectin receptors. These are specific to recognizing fungi, and the Rig-like receptors that detect viral DNA, as you can see here. So how do these recognize the viral DNA? How does this recognize the fungal glycans compared to human cells? How is this like non-specific? So all of them use like a D sugar, not just glucose. They could use glucose, but there could be like lecithin or whatever, right? But it's a D type versus our human cells, which use L type. So if you don't know what I'm talking about, review chirality. So all of them have D-type sugars on the capsid or the cell membrane. So that's how our cells, the Rig-like receptors or the C-type lectin receptors, recognize. Another example is GPCR. They're going to recognize N-formyl methionine residues of the bacteria. So our cells don't have these. This is why they are non-specific. And mannose receptors are going to recognize mannose. But we do have mannose in the body, but it's an L-type mannose. There's a lot of different types. Toll receptors, TLR and TLR4, TLR2 are the ones that respond to the pathogens, and all these are going to be your C-type lectin response or receptors, and all of them eventually lead to chemokine or cytokine productions and induction of phagocytosis. Adaptive immunity or cellular immunity is going to involve your B cells and your antibodies. And these are specifically for the extracellular microbes. So this is not going to work for intracellular bugs and viruses in particular. That's why HIV is such a problematic virus. So the cell-mediated immunity is going to be responsible by the T lymphocytes, and those are going to be responsible for your intracellular microbes. So these are going to target the bacteria that grow inside the cell, and these lymphocytes are going to go through clonal selection once activated. So some of them, the precursor to all of these cells, depending on what is needed, what cytokines are secreted. So if you have a extracellular microbe that has infected a cell, the cell's going to release like DAMPs. DAMPs are going to be picked up by like other cells, and they're going to be transported into like lymph nodes and that's going to activate the colon selection. So those precursors, or in the bone marrow, and those precursors are going to differentiate in either B lymphocytes or T lymphocytes. The natural killer cells are going to be they're going to kill the cells that are irreversibly stressed or abnormal cells. So the ones that have been infected and the ones who are tumor cells. So CD16 is the Fc receptors for the immunoglobulin G, and that gives the NKC the ability to lyse the IgG coded target. So they bind and basically pops the cell. NKG2D is going to be the activating receptors, and it also secretes interferon gamma to activate the macrophages. So the natural killer cell will come in, bind, their CD16 is going to bind to the cell with the IgG. That cell's going to pop, and then NKC is going to be releasing interferon gamma to have the macrophages come out and clean up the cellular debris. So the natural killer cell doesn't actually clean anything up. It just comes in, pops the infected cell, and the phagocyte has to come and clean up. B cells are going to be in the follicle, so right here, of the cortex of the lymph nodes. And the B cells that have been exposed are going to be in the germinal center, and that develops into the plasma cells, and those make antibodies. So the matured plasma cells are going to be in the center. Normal B lymphocytes are going to be in the cortex. The T cells are going to be in the paracortex, so in between of the lymph nodes. And the CD8 T cells, the killer T cells, are going to recognize the peptides with MHC1. CD4 cells are going to be recognizing the peptides with MHC2. So in the adaptive immune responses, CD4 cells are going to also produce the chemokines. The isotype switching and affinity maturation will happen in the germinal center, which kind of makes sense. So it's going to germinate all of your mature cells. Dendritic cells are going to be the most important antigen-presenting cells for initiating the cellular immune system, and that is going to be in the epithelia. So think skin, mucosa, respiratory tract. Those will also produce the cytokines. Makes sense, they're the first line of defense, so they have to send up the signal. The Langerhans cells are going to be the immature dendritic cells. The follicular dendritic cells are going to have the Fc receptors for IgG and receptors for the complement protein 3, and it's going to trap the antigens bound to the antibodies or the complement proteins. Macrophages are antigen-presenting cells, and they are a major source of the cytokines. See, dendritic cells make some, but these make the most. These are going to be the effector cells. Okay, so all the different types of hypersensitivity. So hypersensitivity type 1 is going to be allergic. So what does that mean? The mast cells are going to release a bunch of cytokines, chemokines that cause an allergic reaction. So these are going to be your vasoactive amines, enzymes, and proteoglycans. It's going to dilate your vessels. It's going to irritate these vessels and tissues. And then the chondroitin sulfate gene is going to package and store the amines in the granules of the mast cells, right? So the lipid mediators are going to be made from arachidonic acid products. So that's why it's really important to target the arachidonic acid products in antihistamine medication, right? So we want to stop all of these being released, and we can all do that by stopping the synthesis of arachidonic acid. So leukotrienes are going to be the most potent vasoactive and spasmodic agents. So prostaglandin D2 is going to cause intense bronchospasm and is made by the cyclooxygenase path. Well, remember from pharmacology, we can inhibit this by giving them aspirin. Platelet activating factor is going to also be working, and that can cause thrombosis and petechiae, like micro clots in the microvasculature as well. So that's on the immediate phase, right? In the light phase, eosinophils are going to be now attracted and by the interleukin 5, and those are going to be activated, and those will release the proteolytic enzymes. So these are going to cause like the major symptoms. Like this is the beginning. This is going to like cause most of the symptoms. Type 2 and type 3 is going to be caused in a way both by complementation, right? So in type 2, the complement is going to be activated, and in type 3 it's going to be because the immune complex are going to be deposited everywhere, and then the complement system will be activated from that too. So type 3 is also known as the systemic immune complex disease, and that can cause the acute serum sickness, and it's a very unpleasant disease. So the patient develops fever, joint pain, rash, lymph node enlargement, proteinuria about like 10 days after. So they think they've gotten better, but then 10 days afterwards, like this happens. So the main morphologic manifestation is the acute vasculitis. So right here, the necrosis of the vessel wall. So like, look how thin these vessel walls are. They're supposed to be a little bit thicker than that, right? And then right here, this is a clot. It's not supposed to be in here. Here's another tiny clot. So these should be clear because they're vessels. They appear as fibrinoid necrosis because of the neutrophilic infiltration and vasculitis. The arthros reaction is going to be the local tissue necrosis from immune complex vasculitis. So in type 2, the deposition of the complement is going to be smooth, as you can see here. It's all pretty smooth. Type 3 is going to be bumpy. So type 4 is a delayed hypersensitivity reaction. This occurs like maybe 2-3 weeks after the original like attack, and it's because it's cell mediated. So of course those take longer, and that relies on the memory cells. So one of the examples is the TB skin test, right? So you want to see if granuloma forms. Here's a nice little granuloma right here. Okay, so autoimmunity depends. It can either be just genetic, environmental, but most of the time it's a combination of both. What happens is there is a breakdown of the self-tolerance, and that leads to infections and tissue damage. Because of that, it activates the self-reactive lymphocytes. So some of them, it could be etiologic, but in other cases, the autoimmune reaction can be due to like medication, infections, organ transplants, stuff like that. But in a genetic component, the HLA alleles are the ones that are going to be damaged. The ones that we want to pay attention to is PTPN22. That causes rheumatoid arthritis and diabetes mellitus 1. NOD2 will cause Crohn's disease, and CD25 and IL-7 receptor genes are going to cause multiple sclerosis. There can be something called molecular mimicry, where the pathogens will try to evade host immunity by mimicking the surface antigens of the host cells, but that actually ends up with the body's immune system attacking the host's actual tissue. And the autoimmune disease are all chronic and progressive due to the epitope spreading. Okay, so a really important disease we need to learn about is systemic lupus erythematosus. It's a higher incidence in women, especially people of like Black or Hispanic descent. It manifests as a malar rash, non-erosive arthritis, renal disorders, neurologic disorders, follicular hyperplasia of the spleen. They're all activated by UV light, and it's a type 3 reaction. So it's going to be immune system deposition, as you can see here. And look how bumpy it is compared to the other one, where the glomerular nephritis was like a lot smoother. So if we do like blood testing, the CQ1 levels are going to be low, and anti-nuclear antibodies are going to be found, along with double-stranded DNA, antihistones, anti-RNA, anti-nucleolar antigens are going to be found too. It's also known as a secondary antiphospholipid antibody syndrome, and the morphology is lumpy bumpy. That's how I remember it. So I immune complex deposition, thickened vessel walls, and there's a rim pattern of antigen antibodies. But just remember lumpy bumpy, and it's going to be so much easier to remember when you're taking the USMLE. How do we treat it? Corticosteroids and immunosuppressants. Corticosteroids to prevent more antibodies formation, immunosuppressants to suppress the immune system from attacking the tissues. Okay, so discoid lupus erythematosus is a unfortunate cousin to SLE, and in this one you get these skin plaques, as you can see here. Erythema, follicular plugging, scaliness. It's a little bit harder to see the scales in a patient of color, so you have to be careful, right? Usually the skin rash is widespread, superficial, and non-scarring, and it can be drug-induced. So if you use hydralazine, procainamide, isoniazid, and D-penicillamine, so these are going to be your like heart medication. This is your like blood pressure medication. This is going to control arrhythmia. This is a antibiotic. Like, gotta be careful about these. Instead of having DNA or double-stranded DNA antibodies, they're going to have only positive antihistone antibodies. Okay, so rheumatoid arthritis is going to be both type 2 and type 4 reaction, and it's going to be manifested as the osteodegeneration. So there's ankylosis, fibrogen, and collagen deposition, so it's going to fuse the joints. Is usually SSS, symmetrical, systemic, and synovial, and it's due to interleukin 17 and deposition. There is going to be something called a pannus forming, as you can see here. So there's going to be erosion, and then the body's going to try and like Band-Aid solution it, and that's called like a pannus. And those are in the Bouchard node and Haberdin's node. So Bouchard is right here, Haberdin's is the distal, is more proximal phalangeal joint. But in clinical practice, we would look at the wrist. We want to see any ulnar deviation. It usually occurs in women over 65, so you want to look at the wrist, see if the hand is starting to bend that way. And if you take an X-ray, there's going to be these spur formation. Juvenile rheumatoid arthritis, a lot rare. The rheumatoid factor is absent, so there's no IgM forming against IgG. This one is not always symmetrical. There's pulsi-articular joint, that just means large joints, but there is no osteodegeneration. Still's disease is juvenile rheumatoid arthritis, along with the severe visual problem, this is going to be associated with hepatitis and splenomegaly, so this is the more severe version. Okay, so the seronegative arthropathies are going to be ankylosing spondylitis, basically when your spine fuses, due to reactive arthritis or Reader syndrome, and that is going to be manifested as conjunctivitis, urethritis, and joint arthritis. Reader syndrome is usually in women. Like I said, it's in women, and it's associated with irritable bowel disorder. So this is reactive arthritis. So can't pee, can't climb a tree, and can't see. Oh, sorry, one more thing. So you want to be testing for HLA-B27. Sjorgren syndrome is an autoimmune disorder where the salivary and the lacrimal glands are going to be affected by the infiltration of CD4 cells and the plasma cells. Usually it's triggered by a viral infection, and it's going to be characterized by dry mucosa in the eyes. And due to that, there's going to be keratoconjunctivitis, so keratin formation, tooth decay, infections, and a loss of taste, thanks to the dry mucosa. Complications, lymphoma can occur. You diagnose it by biopsy of the lip, and you're going to try to find Rho or LA, so SSA or SSB antibodies. So systemic sclerosis is a chronic inflammation, and it's widespread to the small vessels, and that can cause progressive interstitial and perivascular fibrosis in the skin and the organs. The excessive fibrosis that begins in the skin, and it progresses to Raynaud's phenomenon. And then from there, renal failure, cardiac failure, pulmonary insufficiency, intestinal malabsorption, and you develop CREST syndrome, which is anti-centromere antibodies in the chest. So CREST is usually found in women due to the excessive fibrosis and collagen deposition. So first, the problem is compressing the vessels, so there's going to be ischemia leading to the Raynaud's phenomenon, and then it's going to continue to the organs, so there's lack of blood flow leading to renal failure, cardiac failure, pulmonary insufficiency, and malabsorption. So malignant hypertension is going to occur. So there are nail folds, capillary loops found in histology, and you diagnose it by anti-centromere or topoisomerase for your DNA testing, and their fingers can't curl in a physical test due to the spasms of the vessels. So CREST is calcinosis, Raynaud's phenomenon, esophageal dysfunction, sclerodactyly, that's why the curling, and telangiectasia. Scleroderma is there's two different types, right? The limited one is limited only to the skin, which is good. The related condition is eosinophilic problems that progress to autoimmune response, vascular damage, and collagen deposition. This is the worst one. This one shows in as right here, the nail fold capillary loops. They're going to be distorted early in the disease, but then they go away once the disease progresses. In the laboratory tests, there's going to be increased von Willebrand factor and platelet aggregation, and they can progress to cor pulmonale and malignant hypertension because of all of the collagen deposition. It's not going to allow the vessels to dilate, leading to hypertrophy of the heart. And then there's going to be pulmonary insufficiency, so it can cause the heart problems. The risks are in African American women. Mixed connective tissue disease is going to be characterized by anti-U1RNP in the labs, and it's a mix of SLE, systemic sclerosis, polymyositis, and you present with like a mix of all of these syndromes. So synovitis, Raynaud's phenomenon, malaise, sclerodactyly. However, this does respond pretty well to treatment. Okay, so inflammatory myopathies are going to cause symmetrical muscle weakness. So people are really going to complain in trouble in standing once they've sat. It's more in women, and it's going to be characterized by something called a heliotrope rash, where the malar rash extends to the eye, and there's going to be periorbital edema, and the color of the rash is like very, very bright. In the labs, we're going to see a Jo1 autoantibody against histidyl tRNA synthetase. That's a lot of words. Remember Jo1. In the dermatomyositis, there's going to be the heliotrope rash, periorbital edema, like I said, but perifascicular inflammation and atrophy in the skeletal muscle. The problem is this could progress into visceral cancers. Polyarteritis nodosa are going to be common in patients already infected with hepatitis B, and it's a necrotizing inflammation of the vessels. Here, the fibrinoid necrosis of the arteries this is caused by HbA and G. Look how thick the walls are, right? Okay, so SCID is an X-linked decrease of T cells, but an increase with B cells with reduced serum immunoglobulins. So it's an inappropriate secretion of B cells. There's no interleukin 7 because of the cytokine receptor. Common gamma chain gene is going to be mutated. It's autosomal recessive, and that's going to cause adenosine deaminase or PNP deficiency. All this leads to problems with the GI and respiration due to the toxic metabolites accumulated, and both humoral and cell-mediated responses are going to be depressed. The lymph nodes in the thymus is going to be atrophic, and usually in children. So there's going to be chronic and recurrent, like thrush. So Candida is a fungus infection, respiratory tract infections, and persistent diarrhea. So this can lead to dehydration really fast. X-linked Agammaglobulinemia of Bruton is an abnormal immunoglobulins due to a lack of light chains. So these are going to be seen in chronic infections from like the flu and pneumonia, but the viral response is normal. So remember, viral response doesn't need the immunoglobulins. There's no cell-mediated immunity involved. So thanks to the abnormal immunoglobulins, there's not going to be any opsonization by immunoglobulin, but opsonization by complement activation is normal. There's also going to be no germinal centers because there's no isotype switching, there is no antibodies produced. And the polio vaccine in these patients can actually produce the disease. Once again, no cell memory. There's more in males, and then these poor guys are going to have chronic pharyngitis and sinusitis with bacterial organisms. Discoid is going to be a thymic hypoplasia thanks to a deletion of chromosome 22. It's going to be a cause of failure of 3 and 4 pharyngeal pouches to form, and it's also known as the catch-22. So cardiac abnormalities, abnormal facies, thymic absence, T-cell abnormalities, cleft palate, hypocalcemia, and it's on 22. So the Wilks-Scott-Aldrich syndrome is X-linked, and it's going to be a recessive defect in the WASP gene. So what's going to happen? Thrombocytopenia, eczema, or atopic dermatitis, recurrent pneumonia, unfortunately early death due to the B-cell lymphoma, and there are very few platelets, so there is a chance of risk of bleeding out because there is abnormal clotting. Amyloidosis is an extracellular deposit of misfolded proteins that aggregate to form the insoluble fibrils, which is problematic because the insoluble fibrils are going to prevent the tissues to be able to expand and contract. So they cause the tissue injury and impair normal function. It causes the pressure on the cells and the tissue, but there are no signs of inflammation. So this can either be localized, which isn't too bad, or systemic, which is much bad. It's associated with monoclonal B-cell proliferations, chronic inflammatory diseases, Alzheimer's, and a dialysis use, because dialysis is pretty traumatic to the body, right? And the constant, puncturing of the needles, unless you have like a port, and even then there's scar tissue always forming, so problematic. Take care of your kidneys. That's it for now. Thank you for your attention, and good luck studying.